on. It looks like I had a technical difficulty on my end. Sorry about that. In the interest of time, we will begin right now, and I would like to welcome everyone and thank you for attending today's webinar. And the nature of this webinar will be fairly technical. The goal today is to review the assessment center costing template that we shared with you on Monday, I believe, with the cover letter that explains the goal and the purpose of why we're collecting this information. And we apologize upfront for the complexity of the costing template. We're trying to accommodate all of the information requests that we're asking in one template, recognizing that there are significant variation in how you structure your assessment centers, and therefore how you will be able to provide this information for us. So we really would like to thank you upfront for taking the time to attend this webinar, as well as to provide the information for us. So the goal of the whole purpose why we ask for this information is that we're simply right now trying to understand what it costs to the assessment center in terms of the ongoing operational cost to provide care for the population, and how the cost drivers and how the overall cost by assessment center would vary depending on the model of care, on the case mix of the population that you serve, and other factors. So it's really to understand the costs. And we do also appreciate that you have been submitting the expense forms to the ministry. And yesterday we had a question about how what's the value of asking this for this information again. And what we're trying to do right now is quite different from what the ministry asked you to provide information for expense report before. Right now, we truly are trying to understand the operating cost, total operating cost, as opposed to net incremental cost from COVID-19 resourcing. So without too much ado, I'm going to pass the receiver to, or the mic rather, to Judith Wong, who is our methodologist, to cover the review of the template and ask any questions or answer any questions that you might have. Just a couple of logistical points. First, a huge plea to please mute your microphones. We will welcome any questions in the meeting chat. Please type the questions in the meeting chat, and we will address them after Judith review the template. So she will walk you through tab by tab, and then we will take all of the questions that we will see on the screen. After this webinar, we are recording this, and we were recording yesterday's session. We will provide the link. We do appreciate that some of you contacted us yesterday, mentioning that the link is not always working. We contacted our IT. We are working on it, so we're trying to find solution to that. We will also be distributing question and answer document based on the questions we received yesterday, as well as the one that we'll receive today. And we will provide that document to you no later than tomorrow by end of day. So with that, I'm going to pass the mic to Judith. And again, thank you very much for all of your help on this.
Thank you, Julia. So I am now projecting my screen that has the template up on it so that you can follow along. If you're unable to see my screen, I will also call out which tab I'm on so you can follow along with your own copy of the template alternatively. So a couple of general context pieces about this template. We developed this template in consultation with a number of assessment center volunteers that agreed to help share some of their experience with what their assessment center operations look like. And we really appreciate that. Thank you to those centers. So this template reflects broadly the diversity of models and services that we observed are offered across the different assessment centers that we interviewed. That means that your assessment center probably doesn't really look like what's in this template. And we fully recognize that this template probably will not be a great fit for any particular assessment center in the province. What we tried to do when developing this template is to provide enough space to capture all of the different models that we're aware of, while still trying to somewhat standardize that information as much as possible, because the next step for us after we get the data back from all of your sites is to try to aggregate it and analyze it, comparing assessment centers to each other. And that's going to be quite a task. So I really want to thank you in advance for the time that you're going to be spending filling out this template. It's not an easy template. It's quite extensive. We've tried to make it as simple as possible, but the challenge for us is trying to make the template relatively simple while still allowing for space to capture the unique features of each assessment center. So that's a little bit of context for you. If you look at this template and say, oh my gosh, this is a lot of information, why do they want all of this? We fully recognize that it's an imperfect process, but it's really a function of the way that assessment centers have developed independently across the province, and us trying to get a handle on that. So the cover page has a few important things on it, so I really encourage you to read through all the information on the cover page. It has some general verbiage about how we are going to be using this information. It's going to be used to develop recommendations to support the ongoing and future COVID-19 testing and assessment in Ontario. Also, I really want to emphasize that this template is focused on the assessment center portion of the work. We have already sent out a template on the lab processing steps and received data back from labs. So any activity related to your lab services, if the assessment center is integrated with the lab, which it may be, don't replicate that information on this template. We've already collected it separately. Other important considerations. We've separated out and provided space for additional services. The main focus of this template is COVID-19 testing services, but if your assessment center does offer additional services such as ED diversion, there is space to capture those. Just make sure they're captured separately under those line items. Another note on scope is that the template is focused on current state operational costs. That means that your past costs, if you had a previous model and you had previous one-time costs, should not be included in this template. In the interest of minimizing the data capture, we want to focus on current state only, not previous state. And when I say current state, when you're filling this out, please think about your last week of operations. So your model as of last week. There is space to capture anticipated future cost if your model is changing in some way, or you're anticipating future one-time costs for whatever reasons. We have a separate space to capture that. Also, if you're unable to give us itemized costs, that's fine. We do prefer itemized costs, but we recognize that may not be possible. You can include total cost. There's generally an option for that. And you can always let us know with a note what is included in the total cost. You can also submit costs to us outside of the template. But as I said, because we are going to be working on the analysis quite quickly for this project, our timelines are quite tight. We cannot guarantee that we will be able to take your information into account if it's not provided in the template format. So getting into the actual meat of the template, the first tab is on your assessment center administration and support staff. The top of this, the top box here is a free text box where you can give us some brief background about your model in general. For example, the geography and population you serve, partnerships across maybe multiple healthcare organizations that run the assessment center, any unique features of your model. And that can include both elements that are particular challenges for you, or things about your model that you think work particularly well. That can all go in this box. As well, if you have multiple different models, you can describe that here, but we will also be capturing the details of those on the subsequent tabs. The human resources section of this tab is where you can enter your personnel that are responsible for the administration and support functions of your assessment center. So these are the folks that will not fit under the specific model services. We expect the admin and support functions to support all of your direct care models. So if you have a couple of in-center sites and a mobile team, this is the administration and support personnel that support all of those teams. There's a few notes here that apply to multiple tabs in terms of how to collect and record the human resources information. So it should be based on last week's data in terms of your number of FTEs, your average hours, and your salary rates. If the hours per day vary, if you're working 8 hours on weekdays and 4 hours on weekends, total your total hours over the week and divide by the number of operating days per week, which you've entered above. If you have multiple staff working at different salary rates, either based on seniority or because you pay a weekend premium, use a weighted average rate across all of the hours. Also a note here, if personnel are not paid out of the assessment center budget, for example, if they're physicians working on fee-for-service, or you're getting some in-kind support from a partner organization, include them in the personnel list, because we do want to be aware of how many staff it takes to support your assessment center. But you may leave the salary rate blank and note the funding source in the notes. So it'd be at OHIP or another health in-kind support from another health organization. Also on this tab, there's some space for supplies, which we're assuming is just office supplies in this case, but there is room for specifying something else, and overhead support. When you're entering this information, we've allowed you to enter cost per day, per week, or per month, depending on what is easiest in your cost structure. A cost for that unit of time, per day, per week, or per month. It will calculate for you a cost per day based on your operating days that you've entered above. As well, the percentage of the cost that's associated with your COVID-19 assessment center. So this could be 100% if you have an office that's 100% on this. If you're sharing space, maybe it's a percentage that's less than 100, and then it will calculate for you what that cost is. Moving on to virtual services. So one thing I want to emphasize about the virtual services tab is not all assessment centers will offer a range of virtual services. However, on virtual services tab is follow-up. So even if you are not running a call center offering virtual appointment booking or other services of that nature, you are probably providing results reporting to patients and or public health. And so the time required for those activities is to be found on this tab. So please make sure, even if you're only offering results reporting, that you complete those sections of this tab. So for virtual services, we're collecting at the top of this tab and subsequent tabs some information about your operations and your volumes. So we want to know your number of operating hours per week total, days per week, which defaults to 7, but please adjust it if it's different. Your maximum capacity, as well as your average, and these may well be different, and your percentage of symptomatic cases. And all of these are your best estimate based on last week. We do not expect you to necessarily track the exact number of symptomatic versus asymptomatic cases that you've dealt with, but try to estimate that proportion for us here. Similarly to administration, the first section is on human resources, which is your personnel, your FTEs, their hourly rate, and the total number of hours per day, which is across all FTEs. So if you have 2 nurses working full days, that would be 7.5 times 2 in this cell here. The personnel are we have general categories for what we think are the most likely personnel types. If your type differs, you can enter other and then specify in the notes who that is for us. Below the HR table, we have a table labeled test process steps. So this is where we are picking up the activity level data from you, which is for each of these activities, who is the staff person that is most commonly carrying out that activity? How long does it take for an average or typical case? What is their salary rate? There is a formula in this cell that will pull the rate from the table above, so you don't need to re-enter it if it's the same, but you can overwrite it if for some reason the salary rate is different from the table above, as well as the average volume per day. So on a typical day last week, how many virtual patient assessments did your virtual assessment center do? If you have more than one staff type that's doing each activity, select the most common staff type from this list and tell us in the notes what the other staff types are. I also want to call out that for some of these activities, we are splitting the activity between symptomatic and asymptomatic patients because we want to understand the differences in cost structure between these 2 patient types. If you spend the same amount of time on patient education and counseling for both symptomatic and asymptomatic patients, enter the same time in both rows. If you only offer patient education and counseling to symptomatic patients, enter the time for this row, and you can leave the other row blank or 0. We also have a section here for results reporting to public health, which we are not asking you to estimate per patient. This one is to be estimated per day, assuming that this will generally be done in more of a batch activity. We also have a section on this tab for additional services. So if your virtual assessment center is also offering non-testing related activities, such as virtual consult services, remote monitoring, maybe patient navigation and referral, you can enter that information here. If this doesn't apply to you, leave it blank. Similarly to administration, same sections are available for supplies, which again, in this case, we assume will just be office supplies, and overhead costs. Next, moving on to the in-person model. So the next tab is the in-center tab. And I'm going to start moving more quickly for these because they're similar in structure to the previous tabs. Each data table we try to structure in the same way so that it's easier for us. It should be easier for you in filling out multiple tables. So similarly, we're collecting operating information at the top, your site location, your hours, your days, your volume information, including both your maximum capacity and your average volume per day, and your symptomatic cases. Again, we're collecting your human resources staff, so that's all your personnel and their average hours per day. Again, we are collecting testing activities. So we have a section on activities that are collected per case, as well as activities independent of the number of cases, which for an in-center assessment center, we assume would be things like security, line management that aren't per patient, but you may well need to have staff on site doing these activities. And additional services per case, similar to the virtual services tab. On this tab, we have a little bit more detail requested for the supplies. So the supplies data, we should a number of general supply categories for your supplies. Sorry, can you please mute your line? So swabs, PPE, etc. If you can, please report supplies in these general categories. Otherwise, you may report supplies under total supplies not itemized as an alternative. Optionally, you can give more detail and then just fill in units per day, cost per unit, and the template will calculate cost per day for you. Overhead, similar to previous tables. And there is a drop down here again with general categories that we expect would be most common. Fill in what applies to you. And you can select other specify if needed. And that is overhead. Okay, the drive-through tab is very similar to the in-center tab in terms of the information that needs to be collected here. The only difference for the drive-through tab is we do not assume you would have additional services the way we have for the in-center tab. There is a line for follow-up instructions or rerouting patient to in-center on this tab, but otherwise we're assuming that the drive-through would be very similar to the in-center and the information we're collecting is therefore very similar on this tab. For your mobile team tab, so the mobile team tab applies to any site visit. So this could be pop-up testing in moving from community to community, long-term care home testing, retirement home testing, other congregate living sites, any kind of mobile visit that is not a visit to an individual patient residence. Unlike the in-center and drive-through and virtual services tabs, the unit of analysis on this tab is per visit rather than per day. So therefore, we are also collecting the number of site visits per week on average rather than the days of operation per week. So if you think about your last week of operations, how many visits did you have in that week? If your average is less than 1, that's fine. Enter a number less than 1. If you have a visit every 2 weeks, that would be 0.5 per week. Again, we're collecting maximum capacity. And then we're looking for the average testing volume per visit, swabs used, and again, the percentage of symptomatic cases. We're collecting human resources for the mobile team in a similar way. Because the unit of analysis is per visit, it would be the hours per visit. We're also collecting the testing process steps and the activities independent of the number of cases. The list of activities is a little bit different for the mobile team, but the structure of the data is the same as on previous tabs. The supplies data collection is the same. And then for mobile teams, we also are requesting information on the cost associated with transportation. So this is the cost per visit round trip to transport your mobile team staff to the site. You can provide the cost broken down into these categories, or alternatively, you can give us the total cost per round trip not itemized. Optionally, we would also like you to, if possible, give us the total distance traveled in kilometers. which will allow us to compare the data and understand the context for transportation, given that our province has such a diverse geography and we expect some mobile teams may be traveling further than others. Next, I'm moving to the mobile team home visit tab. This tab is essentially the same as the site visit tab in terms of its structure. The activities are a little bit different, as we're assuming there wouldn't necessarily be the same kind of the list of activities is a little bit shorter on this tab because of the nature of the visit type. We are not assuming that your volume per visit is necessarily going to be 1. It may be 1, and you can fill that in here if that's the case. But just fill this in based on your average number of visits and your average volume per visit, as you've done for the other mobile team tab. So those are all the different models. In general, please fill out every tab that applies to your assessment center. If you don't do mobile team home visits, don't fill out this tab. If you don't do particular activities, don't fill out those activities. So fill out everything that you do, but you do not need to fill out anything that doesn't apply to your site. If you have, we had a question yesterday on if you have, for example, multiple in-center assessment centers. If you have, say, 3 different assessment center sites, how do you fill that out? You have 2 options in that case. If your 3 sites have a similar cost structure, so meaning your testing process steps are about the same, your time per patient is about the same across each of those 3 sites, your activities offered are more, well, even if you offer additional services at only 1 site, that's actually fine because you're going to give us the volume per day, and that would be the volume at that 1 site. Your supply costs, your overhead costs are more or less the same. If that's the case, you can fill out 1 template, enter your total FTEs and your total hours across all 3 sites in the top table, and enter your average or typical patterns in the tables below. That's perfectly acceptable, and we'll take that as the sort of average and total cost across all your sites. If your 3 sites have quite different cost structures, you can alternatively submit 3 separate templates to us with the information filled out differently for each of the 3 sites. That's also acceptable. Just let us know when you email us the results that that's what you have done. Okay, moving on now to the specimen transport tab. This tab, again, may or may not apply to you because we're aware that labs sometimes bear the cost of transporting specimens from the testing site to the lab. So just let us know if this applies to you, the number of days per week, whether you are responsible for the cost, or if you're responsible for the cost a certain percentage of the time. Fill in as much of this second table as you're able to. So the number of samples transported, the number of trips, number of kilometers traveled. Again, these are different metrics that will allow us to compare data across different sites. You have the option to give us your costs per day, per week, or per month, whatever the logical unit is for you. And then this calculator will convert the costs you enter into a total cost per day. And similarly, you can give us the cost broken down by these line items, or otherwise you can give us the total transportation cost not itemized. It's just quite important that you tell us whether you're bearing transportation costs and the number of samples you are transporting. Okay, the summary tab. We are almost at the end. So the summary tab does not require you to enter any information. This tab is more for your information to show you how the information that you have entered on the previous tabs is being rolled up. So this tab is a little bit complicated. It has a summary of the cost per day under each of the models, including your administration cost, or per site visit for the mobile team tabs. So these columns pull data from the previous individual model tabs to collect your volumes, your percentage of symptomatic, your operating days, your FTEs, and your cost, which is per day or per site visit here. Then the column on the left pulls together a total cost per week, which is calculated by multiplying the cost per day or the cost per site visit by the number of operating days or the number of site visits per week. So each of these values on the left are going to be a function of the cost per unit times the operating hours or the visits to give a total cost per week across all of your models combined. Useful to check this tab to see that your costs are showing up the way you expect them to. You know, if your cost per day looks really off, maybe go back to the source tab and see if there's a piece of information missing. If your number of FTEs is adding up to a higher number than you know you have, maybe go back to your source tabs and make sure you're not counting the same person in multiple categories. It also gives some breakdown on the labor activities for asymptomatic versus symptomatic patients, which I had highlighted earlier. Some of the activities we're capturing differently for asymptomatic versus symptomatic, so we can understand the difference in cost between those patient types. The additional services, as well as the labor costs independent of the number of cases. We also have a summary of your transportation cost on here as well, and your total cost per week with transportation included. So this tab is really just intended to be a tool for you to sort of cross-check your work, see that the numbers look the way you expect them to based on the information you've entered. Okay. Last two tabs. The other cost tab may or may not apply to you. We're looking for information here on both costs covered by other entities. So this could be in-kind contributions from other organizations, free space offered by your city, or costs covered by OHIP. So you can provide those for us here. As well as what the cost is if you are aware of what that cost would be if you were incurring it. There's also space for future costs. These can be one-time or operational costs. And let us know some context here if you enter costs on this tab. So it could be anticipated future costs for sustaining your current model. If you're planning some sort of process improvement or innovation in your model, and there are some costs associated, you can include that here. If you're anticipating some cost savings because of this process improvement, you can enter that here as well and just put the cost as a negative cost. Finally, we're also collecting some information for our colleagues, and this is what Julia mentioned in terms of we're going to try to avoid bombarding you with multiple requests, which means this template is a little bit bigger. We're collecting some information about your use of the provincial virus test requisition. whether the order is being placed in your health information system or lab information system, and whether that information system is interfaced with the performing lab. So please do complete this tab for us as well. And with that, we will go to questions.
So thank you so much, Judith. We only so far received one question from this webinar, and that was to maybe elaborate a little bit more on what the definition of emergency department diversion service is. And we've covered that a little bit. So based on the interviews that we had so far with select assessment centers, our understanding is that some assessment centers expand their services a little bit beyond what is essentially required for COVID-19 purpose, and serve a little bit like the points where patients receive primary care as well as potentially urgent care, and that allow those patients to avoid going to the emergency department. So if that's how your center is organized, that's what we meant by that. And Judith, if you want to extrapolate a little bit more on that, if you have anything to add, please go ahead.
Yeah, I think Julia's covered it. So in our interviews, there are some assessment centers that have, as part of their mandate, explicitly one of their goals is offering ED diversion services. So they have additional staff or staff doing a few different roles. And if that doesn't apply to your center, please leave it blank. We also have space for primary care services if that is part of your assessment center model. So within the assessment center, if you offer these other services and you have assessment center staff providing these services, this is the space to collect it, but that probably doesn't apply to every assessment center.
Thank you. The next question is, if we share resources FTE with community testing site on an ongoing basis, would situation go into mobile team?
I'm not sure what the meaning of a community testing site is.
So maybe you could extrapolate a little bit on your question, and while you're doing so, and before I read the next question, I just also want to emphasize that if your resources are shared between the two models of care, then do your best to split those resources. For instance, if you have, let's say, 5 FTEs of the same type and they're shared between the two models that we split on our separate tabs, do your best to split them, but we would not recommend spending a lot of time to make it precise, in the sense that this is not meant to be an exercise that would make you do the time and motion studies or separate analysis to provide us with this information. Do your best to provide it based on your judgment, and don't go into trying to be precise. So we will take that, and we appreciate all of your help as is. Yes, so to try to be, we're trying to be as respectful of your time as we can. So just do your best. And hang on a second, we received quite a few questions in the last 10 seconds. Give me 1 second. Are you planning on sharing any best practices on how to run assessment centers? So I would say that maybe this is something that we're looking into in the future. This is internal work that is being done in Ontario Health in conjunction with potentially the ministry, but the purpose of the current exercise is to understand the operating cost based on your current structure. And we will take that as input into more strategic work. I don't know if Vicky has joined us and she has anything to add. So right now, this is something that we're looking towards essentially, but it's as a part of the next steps. It's not part of this specific information collection. The findings from this analysis will go as an input towards more strategic thinking about what the situation should look like going forward. Next one, did I understand correctly? We are to include in-kind support in cost calculations within the model we operate, but we are also to list them separately in other cost tab.
Yeah, let me try to
Yeah.
clarify on that one. So for in-kind support, you have a couple of options, but the key for that we want to make sure we capture in terms of in-kind support is your personnel, because we want to make sure we understand the number of people it takes to operate your assessment center and offer testing services. So for people, make sure that you do enter them under your human resources, even if they are in-kind support. And then you may optionally, so if you've put them under your human resources and said in the notes that it's in-kind support from X organization, you do not need to report them separately under other costs. You can optionally report them here as well if you want to make sure that we see all of those in-kind costs together. So for personnel, please make sure you put them in the HR table where they're working so that we see those hours, even though we don't see the amount. For other things like leased space, and other non-personnel costs that you may get in kind, our intention is to have those captured here on this other cost tab. If it's easier for you to put them under the relevant model, I'm going to say that's fine. Just make sure if you put them, for example, if you have leased space and it's easier for you to report it under the relevant model, make sure you note that it's in-kind support and the cost to your assessment center is 0. So I realize that's not completely clear. To recap, you can put the item either under the main table with a note saying it's in kind and the cost as 0, or put it in this other cost tab. So you have the option to do either for most things except for personnel, where we really want to make sure you put the personnel under whichever model they're working. So if you have in-kind for your in-center or your mobile team or your admin, put it under those respective models.
Thank you. Next question. We are a family health team running an assessment center. Do you want to IHP HR costs? I think IHP is individual health practitioner, if I'm not mistaken. HR costs broken out, or do you want that entered as an in-kind? Currently, we are funding these positions through a family health team. However, that is dependent on board approval as primary care opens up in the future.
Right. So since those are currently being provided as in-kind and the focus of the template is current costs, you would put those as in-kind currently. So you would enter the personnel and you would note the current funding source is your family health team. But then I would also suggest that under future costs, you flag that may change in the future and what the future cost could be under this section of the template here, other costs, future costs.
Okay, thank you. Back to that question, we received clarification. So we're going back to the question, if we share resources FTE with a community testing site on an ongoing basis, would a situation go into mobile team? So the clarification was, we have an off-site location for testing shared with a community center.
Okay. So I guess if the community center is reporting, it will be sending us a template, right? So if that community center is sending us a template, then those costs should be reported on their template. Right? So if you are contributing in-kind staff to another assessment center, then your staff should actually show up on their template so that we understand the full scope of costs that are associated with that testing site. So if I'm interpreting what this model is, it's that you're sending your staff to support another assessment center. That assessment center should be sending a template to us that reports all of their costs for running that site, and that would include your staff supporting that. So they would report your staff on their template and note that it is in-kind support from you.
Thank you. So we have the question, I will read it out, but we pretty much answered that. Some sites have in-kind resources, several FTEs. Where do we quantify those third-party costs? So I believe we already answered that, correct? So John, let us know if we didn't. So next one is, our local paramedic team through District Social Service Board has been providing the mobile service independently. Should we include them in our submission, or shall they submit on their own? They were not invited to the webinars. So again, let me read it again. Yeah. Our local paramedic team through District Social Service Board has been providing the mobile service independently. Should we include them in our submission, or shall they submit on their own? They were not invited to the webinars. And I don't know, Judith, we may have to take that one offline if we can't answer it now.
Yeah, I think we do want to make sure that we capture that information. It may be easier for them to submit if they are if they're the ones providing the service delivery. They may be the best people to submit directly, but we should probably make sure that we have their contact information.
Right. So the next question is, you may have addressed this earlier, but will we be reimbursed for these extra costs? Harry, what extra costs you are referring to? I'm just trying to find your earlier email, sorry. Are you planning on sharing any best practices or how to run assessment centers? And then the follow-up question from the same individual was, yes, running an assessment center. Will we be reimbursed for this extra costs? So my understanding is that the current reimbursement is based on the expense form that you submit to the ministry, right? And we will be, hold on a second. So my understanding is that currently you are being reimbursed using the expense process and submitting the expense reporting forms to the ministry, and we can take it offline and provide more clarification. So the goal of this information gathering is to understand the cost on and potentially incorporate it in the future decision making. And but as for reimbursement of the current processes, we will have to get back to you. I am not quite sure exactly how that's currently working, because we haven't been, our team has not simply been involved in this process of expense reimbursement. I apologize. We may have to get back to you, separately on that. We have the same issue with shared service with paramedics. My plan is to have them fill in their information and submit it as one response for our OHT subregion, as we are providing this shared service in our area. Is that okay? So I believe so. Julius, what are your
Yes,
thoughts? I believe
absolutely.
that
So,
would be.
yeah, so I think this is, the way you framed it is you're providing shared services. So if you are working in partnership with another organization like paramedics, and I think it makes perfect sense for you to submit one submission. Obviously, working closely with them to complete the sections that are applicable to their team. But that works better, particularly if you're offering, one set of virtual services, one set of administration and support for your whole region. I think that makes perfect sense in the case of partnerships. And if you're working with, if your region it has, multiple sites offered by family health teams or community health centers, I would encourage you to work with those sites as well to put together a submission if that's what is most applicable to your region.
Who should we have the paramedic team contact as per your direction from my previous question? Again, hold on a second, Paula. Who should I have the paramedic team contact? So the question is, who do we need the paramedic team contact as per if there is a joint? Paula, what I think we'll do is we are recording all of these questions, and when we distribute the Q&A document, we will try to provide the answer for the contact information on that document, but because we may have to loop in internally and figure it out piece internally, so I'm not going to confuse everybody on the call right now. And so yes, and the same concerns about the same question, the same comment probably is pertinent to the question about previous reimbursements. So we will loop in internally, and if it requires more time for us to loop in and answer the question, so that we wouldn't have to hold up all of the document, we may have to loop in and provide that clarification later on, but we will try to distribute it via email in the email form. So again, hold on a second. We are not an OHT, but should have paramedic team be part of our submission. Is this correct from what you just said? So the question is, should the paramedic team be resources on the paramedic team be included as part of the submission?
So what I would say in general for all of these questions is, if you are working in partnership with a paramedic team, and you have a good working relationship with them, you're in contact with them, and you're able to fill this out together, working together to submit because you have that kind of working relationship and you work together, then do that. If the paramedic team is independent of you and you don't work with them, then I think it would be easier for them to submit independently. So it's really about what your working relationship is like. If you work in partnership and you are able to submit a joint submission with all of your input taken into account, that's fine. If you don't work in close partnership and that would not make sense for you to submit jointly, then I think it would be separate submissions.
Thank you. Next comment and question. We are a small community assessment center, highly variable volumes ranging from 400 to 300 tests per day. Should we take the average costing over the last 3 months as our reference?
So I would say not 3 months is too long, because we really want to understand the current state, and I think a lot has changed over the last 3 months. I totally appreciate that your volumes vary a great deal. I would encourage you though to focus on the last week because that's going to be more representative of your current state. Even if you don't feel it's representative of the last 3 months, because, you know, I don't know that the last 3 months are really going to be representative of the next 3 months.
Right.
If it
Yes.
makes more sense for you to use the last 2 weeks, if that makes you more comfortable, I think that's fine. But don't go. I would really discourage you from going too far back in time. Think of this as more of a snapshot. We recognize that it's imperfect, and it's really a challenge because you know, we don't really know what the future holds and what the future state is going to look like. So we are trying to you know, get the best information we have, with the caveat that, of course, current state snapshot is not going to necessarily be a perfect indicator, and it has limitations.
Thank you. If swab lab testing is being provided and paid for, or laboratory processing is being paid for and paid by another hospital, who should be reporting cost in order to have cost per visit accurate? So please exclude all of the lab processing and transportation cost about the lab specimens from this particular template. We are collecting this information in another stream of work that we're currently doing. So don't include any lab associated cost for processing the specimen and follow up in this particular template. We're looking at that. The cost per visit will be complete. It's just not in this template.
And I think swabs was mentioned in that question as well. So if your swabs are provided to you at no cost, don't list them as a cost for you. You can optionally provide your volumes. So if you want to give us your swab volumes, you can optionally do that. Just list the units per day and the cost per unit as 0, because we know that the cost may be 0 for most sites.
Next one, our local long-term care homes do their own testing independent of us. I understand they must submit their own report, and have they been provided this document? So this distribution list that we share, this document, have been provided to us by the team who has a full list of the assessment centers. So if my understanding, if that long-term care home does the assessment center activity and is one of the assessment centers, they would have been provided by the list, they would have been provided with this document. So I would invite you to just make a note in your submission and see and we can make sure that it's part of that distribution list. But we shared this document to the whole list of assessment centers, however many there are, about 142 or so in the province. So my understanding is, yes, if they are assessment center, they would have been provided with this document. So I believe this is the end of the questions that we've received today. And we're at time, actually. So thank you so very much for attending the webinar and for all of your work. We do appreciate it. As a next step, we will be sharing the link to the video recording as well as a Q&A document. We will try to address all of the questions and a couple of those that we weren't able to answer during the call in that document. So stay tuned. Thank you again. And with that, we will conclude the webinar for today.
Thanks so much, everyone.